This time I want to talk about some cardio-respiratory interactions and the concepts of preload and afterload, interdependence between the ventricles, and fluid responsiveness, which are important hemodynamic concepts. So we talk first about preload. There's lots of different definitions that people have in mind, but I want you to think about preload in terms of the myocardial fibre length just prior to the onset of contraction. So this is the load on the fibres due to their stretch, which essentially is due to the volume in the ventricles. And if you, just as an analogy, I don't know if you ever did any physiology labs where you had some of these muscle preparations and put some load on the muscles with some weight and measured the tension in the system. So this is the tension in the muscles just due to the weights hanging on the muscle before you initiate the trigger the contraction. Because of the shape of the ventricle, this discussion always includes some consideration about the law of Laplace. So just remember this, that the tension in the wall is related to the radius of the vessel, and the pressure in the lumen. It's actually the transmural pressure. It's not really shown in this picture, but it's the pressure on the inside relative to the pressure on the outside, which is important, and also the wall thickness. So this next picture just highlights some of these concepts intuitively, that you know that the pressure in this balloon is the same throughout, but intuitively the tension in the wall is much greater in the part that's got the greater radius, and the tension in the wall where it's got a small radius is much less. So that's relevant as well. One of the problems with thinking about volume as preload is that it's not so easy for us to measure volume. It's much easier for us to measure pressures such as CVP and pulmonary artery occlusion pressure. But one of the ways that we can measure or estimate volume in the ICU is using echo and using the Simpson's rule for measuring the volume. So if you've ever seen the echo techs making this kind of measurement, basically they're outlining the shape of the ventricle and dividing it up into about 20 slices, and so if each slice then is calculated to become a disc with a certain diameter and the known thickness, they can calculate the volume of each disc and add those together and come up with an estimate of the volume of the ventricle. Thinking now about the afterload, again, we have various different descriptions in mind, and in simple terms it's the force opposing the ejection of the blood from the ventricle. But it's actually the transmural systolic pressure in the aortic root on the left side, or in the pulmonary artery trunk on the right side. So thinking about the afterload from the left ventricle, on a spontaneous inspiration, the transmural pressure increases due to the negative intrathoracic pressure. And so this actually increases the afterload on the left ventricle. Conversely, in thinking about a situation of positive pressure inspiration, so a ventilated breath, then the aortic transmural pressure is going to decrease due to the increased intrathoracic pressure on inspiration, and that decreases the left ventricular afterload. Thinking about the right ventricle, the positive pressure inspirations increase the RV afterload, mostly due to the compression and the collapse of the pulmonary capillaries. So essentially it's turning, if you remember the west zones, and we'll talk about this more next time, but it's converting sort of zone 3 areas that are perfused into zone 1 or 2 areas where the alveolar pressure is greater than the capillary pressure. The effect of spontaneous inspirations or negative pressure inspirations is a bit variable, but it tends probably to decrease the right ventricular afterload initially, as the pulmonary circulation is opened up by the expansion of the chest and the negative intrathoracic pressure sucking blood into the pulmonary circulation. So if we build on that and just think about the effects of PEEP or CPAP, so this is going to decrease the transmural pressure of all the chambers and the aorta by applying pressure to the outside. So decreasing that transmural pressure, it's going to decrease both the left ventricle and the right ventricular preload by the pressure on the outside of those chambers, which again by that law of Laplace, you're decreasing that the transmural pressure, you're decreasing the wall tension, maybe also slightly reducing the radius, so you'll be decreasing the preload. Increasing the right ventricular afterload by its effect on the pulmonary circulation, and decreasing the left ventricular afterload by its effect on the transmural aortic pressure. It's also going to decrease myocardial oxygen consumption by decreasing that muscular wall tension, particularly during contraction. So to summarise that point then, PEEP causes decreased filling and increased emptying. And the net effect on cardiac output depends on the relative effects of those two changes and the filling state. So obviously we're hoping that it's going to increase cardiac output, but you know that if you have an underfilled patient and you give them a lot of PEEP, then you can actually cause hemodynamic collapse. So it depends on the relative effects of those two things. The next important concept that I want to think about is this notion of interdependence. It's a bit, I think it's a little bit like analogous to the Monroe-Kelly doctrine in the head, that basically we're talking about something that's constrained by a rigid pericardium. So if one space dilates, it has to be at the expense of another. And so here, particularly if the right ventricle dilates, it must be at the expense of the space that the left ventricle occupies. Essentially, this is causing decreased left ventricular diastolic compliance. If you think about it, if the left ventricle is squashed to sort of smaller than the normal size by the septum shifting across, then its volume is going to be smaller and you're going to have to give an increased filling pressure to achieve the same change in volume, or conversely for a normal filling pressure you're going to get less change in volume. So that by definition is a worsening of compliance of the left ventricle. The compliance is also going to be worsened by other external pressures on the heart, or particularly on the left ventricle. For example, pericardial effusion or increased intrathoracic pressure will also make it harder for the left ventricle to fill, and the diastolic compliance will be worse. So this ventricular interdependence and the septal shift, it's induced by a changing right ventricular outflow, and in particular increasing pulmonary vascular resistance. So this relates back to what we were talking about in the previous talk. So it can be, PE would be a good example of an acute increase in pulmonary vascular resistance that potentially could cause the right ventricle to dilate and the septum to shift across to the left. Hyperinflation of the lungs will do it, so a high PEEP, a large tidal volume, or recruitment manoeuvres will cause this. And you may have seen, if I've shown any of you, the staircase recruitment manoeuvre when you're up to sort of intrathoracic pressures of 50, that the blood pressure and the cardiac output drops. You really need to have them well filled. You need someone really turning up the noradrenaline while you're doing this, because it sort of chokes the output of the right ventricle. It shifts across and squashes the left ventricle and really drops the cardiac output. So this is an example of acute cor pulmonale with this right ventricular dilatation, particularly in diastole as a sign of diastolic overload, and this paradoxical systolic motion, particularly of the septum, which is a sign of systolic overload. And if you've got if you're measuring CVP and pulmonary artery occlusion pressure, if the right sided pressures are greater than the left side, then that's a bad sign that the right side's failing. The other thing is to remember that the ventricles are in series, so there's most of what we've been talking about is referred to as sort of parallel interdependence, and then there's also series interdependence, and the fact that the filling of the left ventricle, so it's not only impaired by the fact that the right ventricle is squashing it, but also if the right ventricle is not pumping much blood through the lungs, then there's not going to be much filling coming to the left side. So it's sort of there's two mechanisms for the underfilling of the left ventricle. So here's just a couple of echo pictures showing some of these things. So on the top left there, an apical four-chamber view showing the right ventricle to be quite enlarged, and as a rule of thumb, if the right ventricle looks to be around about the same size as the left ventricle, then it's enlarged. The left lower picture there sort of shows a short axis view, and again you can see that the right ventricle looks very large compared to the left side, and that the septum is flattened and the left ventricle has a kind of a D shape rather than a round shape. On the top right, this is similar to one of the pictures again I showed you in the previous talk. So this is a continuous wave Doppler measuring the velocity of the regurgitant jet, the tricuspid regurgitation. So just measuring the velocity of flow along that line through the tricuspid valve, and the Doppler wave there sort of showing that velocity from which you can calculate the pressure gradient across that valve as an indication of pulmonary artery pressure or pulmonary hypertension. And then the bottom right there just showing that the distended IVC also as a sign of high right-sided pressures, maybe right-sided failure. So moving on from here, this starts to highlight why pressures are poor measures of preload. So if we think about the argument for using CVP as a preload measure, we're hoping that CVP reflects right atrial pressure, and we're hoping that right atrial pressure reflects right ventricular end diastolic pressure. And similarly on the left side, we're hoping that pulmonary artery occlusion pressure reflects left atrial pressure, and that is an approximation of left ventricular end diastolic pressure. So I always say that there's a few sort of steps and assumptions in there as it is. But the trouble is that there's also this sort of unknown, in any particular case, really an unknown correlation between the end diastolic pressure and the end diastolic volume of the two ventricles. And the relationship just depends on the compliance of the ventricles, which we sort of touched on. And this compliance changes depending on things like ischemia, the interdependence, the intrathoracic pressure, things that we've talked about. So some examples here. If you've got really a stiff ventricle with poor compliance, you can get a high filling pressure and a low volume. So actually in terms of the volume and the diastolic fibre length, that the preload could be low, but the pressures that you're reading are high. Conversely, you can get low filling pressures and yet have a normal preload volume if the compliance is high. And this should be the case for any of us. Normally, the CVP in a healthy person who's not intubated is around about 0. So if you measured that, the filling pressures are pretty low. But hopefully my preload volume is adequate just at the moment. So I'm assuming my compliance is pretty high. Another example that highlights the problems in patients with ARDS, if you're progressively increasing their PEEP to try and maintain their oxygenation, then you're going to get decreased left ventricular compliance due to the two mechanisms we talked about, both the interdependence, because that high PEEP, high pulmonary vascular resistance, the right ventricle dilating and the septal shift towards the left is going to decrease your left ventricular compliance. And also just the increased intrathoracic pressure from the high ventilating pressures is also going to be decreasing the compliance of the left ventricle by compressing it from the outside. So in this situation, you're going to have increased filling pressures if you measured them, but a decreased left ventricular end diastolic volume because of that poor compliance. So it's just a couple of examples of why the measures of pressure are really poor markers of preload. So we start to think now about how some of these are affected in initially spontaneous respiration and then in mechanical ventilation. So in spontaneous respiration, on inspiration, obviously we've got negative intrathoracic pressure. So this increases the blood flow into the thorax and into the right heart. And because the heart, if it can, will pump out what it gets, this increases the right heart output. Because the right heart's nice and full, maybe there's a little bit of septal shift towards the left ventricle, but that's probably fairly minimal. Because remember, to get shift, the pressure on the right side is going to have to be greater than the pressure on the left side. During this spontaneous inspiration with negative intrathoracic pressure, there's increased pulmonary vascular capacity. So the pulmonary blood vessels are opened up, and as a result of that, there's sort of damming or pooling of some of the blood in the lungs. That's just not moving forward to the left ventricle because the blood's able to sort of soak up some of the capacity of what's ejected from the right side. So there's actually decreased left ventricular end diastolic volume, or decreased left-sided preload, and decreased left ventricular output for a while there. So this is actually the normal pattern that left-sided stroke volume and output decreases on inspiration. If this pattern's exaggerated and it's more than about sort of 10 millimeters of mercury of swing, then that's a condition of pulsus paradoxus that we sort of see sometimes with tamponade and constrictive pericarditis and asthma and different conditions. And so this normal pattern here is highlighted here with some pressure tracings from the left ventricle and the right ventricle, just showing that on inspiration, the right ventricular pressure is increasing as you've got all the extra blood coming into the right side and being pumped out by the right heart. Meanwhile, on the left side, you're actually not getting so much back to the left side, so left ventricular pressure is falling initially. The other interesting thing you see here is the first couple of beats after expiration, the left ventricular pressure suddenly shoots up, and that's due to the lungs kind of emptying, squashing down, that pulmonary circulation being emptied, and an extra sort of 100, 150 mils being returned to the left side, and the left-sided output suddenly sort of shooting up. If you look now at a mechanically ventilated patient and a positive pressure inspiration, so on that inspiration there's positive intrathoracic pressure. So this is going to decrease the blood flow into the thorax and to the right heart, and you're going to get decreased right ventricular end diastolic volume, and the septal shift is going to improve. There'll be less septal shift. It also causes, as I mentioned there, some. This is almost like a spontaneous sort of expiration. There's going to be emptying of the pulmonary vascular capacity by the airway pressure squeezing the blood out of the lungs. So there'll be initially an increased left heart filling for a couple of beats, but then after that, because the right-sided output, the right side is less full, the pulmonary pressures are increased, so it's not going through to the right heart, through the left heart. Then after that first couple of beats, when the left-sided output goes up, then it will sort of go down as the left-sided filling is reduced. So that's sort of displayed in this picture here. So the top two traces are both the same. They're just highlighting different things, which we'll talk about in a second. But you've got the arterial trace there, and then at the bottom it shows you where the positive pressure ventilation happens. So if you look, as the ventilation starts, there's the lungs are sort of, the blood is squeezed out of the lungs and delivered to the left side. So the arterial pressure goes up as the left-sided output increases a little bit, and then it sort of tapers off, and particularly after a couple of beats and around the time the inspiration's finishing, the pulmonary pressures go down, blood's able to return to the right heart and then to fill up the pulmonary circulation, but there's a bit of a lag before it gets to the left heart, and so the arterial pressure actually drops there. So if you're looking at that middle trace, compared to sort of a baseline arterial pressure, there's this little, what they call the delta up, which is the increase in systolic pressure during the mechanical inspiration, and then there's the delta down, which is the decrease below baseline due to the decreased delivery of blood back to the left heart at the end of, or after the end of inspiration. So, and the difference between those is called the systolic pressure variation, that's the SPV. Looking at the trace at the top there, some of the other things that change are the pulse pressure, so the difference between the systolic pressure and the diastolic pressure being the pulse pressure, so that changes from maximum there sort of on inspiration down to a minimum there on expiration. And the other thing that can be which changes is the stroke volume. So it's possible that those dark shaded areas there under the outline trace up to the dichrotic notch. From that you can calculate the stroke volume, and so that's changing as well. So there's a couple of parameters then which we talk about: stroke volume variation, systolic pressure variation, and pulse pressure variation. And the pulse pressure really, if you just from within a couple of beats, the tone of the arterial system is going to stay pretty much the same. So the pulse pressure is really going to be a reflection of the stroke volume. If you've got a bigger stroke volume, you're going to have a bigger pulse pressure, and vice versa. Obviously, if the compliance of the whole arterial system of the aorta particularly changes over time, then that's not going to be so accurate anymore. But over a short space of time, pulse pressure variation is really going to be a reflection of stroke volume variation. These things are all going to be also affected by the tidal volume and the PEEP in ways that we've kind of touched on before. So here's just some examples. This is from some dog experiments just to demonstrate this, comparing the effects of spontaneous ventilation and positive pressure ventilation on the left and right ventricular outputs and things. So if you look down, the second last trace at the bottom there shows the pleural pressure. So this is initially on spontaneous ventilation on the left. You can see the pleural pressure drops a little bit. And with that, looking at the top now, the right ventricular stroke volume increases. That low intrathoracic pressure sucks blood into the right heart, fills up and pumps it out. The effect on the left ventricle on this is not as prominent, but you can see that the left ventricular stroke volume decreases as we were mentioning, that the blood gets held up in the lungs as the pulmonary circulation opens up. Less of it's delivered to the left heart, and left heart stroke volume decreases transiently. Comparing that now to the positive pressure situation, again, the second last trace there, you can see that the pleural pressure is increased with positive pressure ventilation, and then again looking at the top, the right ventricular stroke volume is decreased as that increased intrathoracic pressure impairs the venous return, and also increases the pulmonary resistance and impairs the blood flow from the right side to the lungs. And then looking at the left ventricle, before we were saying the first couple of beats you may get some increased stroke volume as that blood squeezed out. You don't really see that so much here. So that's the delta up is pretty small, if anything, but you certainly then see the delta down for the last couple of beats of the left ventricular stroke volume, as the left side gets sort of starved because there's no blood coming from the right side, or there's decreased blood coming from the right side. And here's a couple of other echo pictures just to sort of demonstrate the same point with increasing PEEP. So we go from 0 PEEP to 5 to 13 as you move across those three pictures. And then you look there, this is looking at the flow out of the right ventricle into the pulmonary artery, and the Doppler flows are recorded there, and the mechanical breath is sort of superimposed on the screen. And the solid white line just sort of is showing where the tips of that Doppler trace in the first picture are. So you can see as you increase the PEEP, even without the ventilation, the Doppler velocity is decreased, particularly in the third one there with the PEEP of 13. And then when you apply the mechanical inspiration on top of that, there's greatly reduced right ventricular outflow into the pulmonary artery. So now if we build on these concepts just a bit more and think about what's the effect of hypovolemia, and in particular, what does fluid responsiveness mean? And what are we trying to achieve when we give a fluid bolus? A lot of the time we're giving fluids to people in shock, but sometimes we don't really think of what is it that we're really trying to achieve when you break it down. So we're all familiar with shock and this concept of inadequate perfusion, and presumably in a lot of, we think about shock being due to inadequate cardiac output for the tissues. We know now probably in sepsis that cardiac output's actually increased, and it may be more of a problem with oxygen utilization in the tissues rather than low cardiac output. But when we're giving fluid, we're really hoping to improve the perfusion by increasing the cardiac output based on our thinking or the simple model that cardiac output's not enough. When you really break it down, the only thing that we can really be hoping to change about the cardiac output by giving fluid is to increase the stroke volume. If you just remember cardiac output, it's heart rate by stroke volume. That when giving fluid, we're just trying to increase the stroke volume, to increase the cardiac output, to increase the perfusion. Now, what we're really trying to work out is who are the patients that would benefit from getting extra fluid, or particularly getting a fluid bolus. If you remember this Frank-Starling mechanism that within limits, the heart pumps all the blood that's returned to it. And you remember these sort of Frank-Starling curves. Sometimes they're drawn different ways. So this one, just with preload along the bottom, that preload, should probably be whether it's myocardial fibre length or end diastolic volume. Sometimes the graph's drawn with CVP or pulmonary artery occlusion pressure as the preload, if that's what they're using. And then on the y-axis there, they've drawn his stroke volume. Sometimes that's shown as cardiac output, but essentially if the heart rate doesn't change, then the cardiac output's related to the stroke volume. What you see here is that if the patient is on the ascending part of the curve, so down the bottom there, then for a particular change in preload, you may get quite a large change in stroke volume. Conversely, once you're up the top towards the plateau of the curve, if the heart's operating up there, then for a large change in preload, you don't get much change in stroke volume. So if we're not getting any improvement in the stroke volume by giving extra fluid, then there's no benefit, and probably there's some harm in giving fluid. So this is the benefit of working out where the patient is on this curve. Are they someone whose stroke volume can be improved by giving fluid, or are they already at the top of the curve? One of the things about being further down, the bottom of the curve there in the steep part, is that small changes in preload will be detectable by changes in the stroke volume or the cardiac output. And the swings in the intrathoracic pressure will cause changes in the transmural pressure of the ventricles, and hence in the wall tension on the preload. And we're able to detect that. But once you're up the top of the curve, changes in the preload aren't going to make much difference at that point. Single static measures of preload, such as a single CVP or pulmonary artery occlusion pressure, if that's what you're using, or even single measures with the ultrasound or with the echo of diastolic volume, don't really predict volume responsiveness, as we don't know the compliance or the contractility of the curve. We don't know the shape of the curve or the position of the curve for that particular patient. We don't know where the curve is, if they're in a state of increased contractility or heart failure. So a single figure is not that helpful. If we could do a trial of treatment and just give them a fluid bolus and see if the stroke volume variation or the pulse pressure variation improves, but we may have given them some sort of fluid that they didn't need. So it'd be nice to predict whether they're patients that are going to respond to fluid or not. So without really knowing where the curve is, all we can say is that if the stroke volume variation or the pulse pressure variation is low, then they must be up the top of the curve. And if the stroke volume variation or pulse pressure variation is high, then they're probably on the steep part of the curve and they benefit from some fluid. And the magic figure seems to be a variation of about 11 to 13%. So systolic pressure variations or stroke volume variations or pulse pressure variations, all sort of measured in different ways, can be used to predict whether volume expansion is going to increase the stroke volume and is going to increase the cardiac output. And these things can be measured or calculated from the Artline trace, or possibly even the pulse oximeter waveform, just with software in the monitors. The slightly confounding thing, if you think back through the things that we've talked about here, is that changes in the stroke volume and the pulse pressure during positive pressure ventilation may either be due to volume responsiveness, or potentially that could be due to interdependence and the cardio-respiratory interactions. And certainly with any patient, if you crank up the PEEP and the tidal volume far enough, then you're going to generate the problem of the interdependence, and you'll create these respiratory fluctuations. So some limitations of this then, I guess looking at the second thing in relation to that the studies that have been used to demonstrate this have had some reasonably standard conditions, so a PEEP of 0 to 5, so not a lot of PEEP, and a tidal volume of 8 mils per kilo, so perhaps slightly more than we'd normally use. But if you're sort of going to use these established cutoffs as a marker of preload or volume responsiveness, then you kind of need to use the same conditions that they've been validated in. Other things are that these variations aren't really proven to predict fluid responsiveness in spontaneously breathing patients or in patients that are on pressure support. They're only really validated for patients that are deeply sedated and or paralysed and having mechanical ventilation. The other thing is that they rely on sinus rhythm, so you need a regular kind of line trace. It's not going to work with AF with fluctuating pulse volumes on the art line. And it's only the pressures are only going to be transmitted and translated with a closed chest and a normal abdominal pressure. So I'll just mention this at the end because I know there is a bit of a flavour for this here, passive leg raise as a measure of volume responsiveness. So essentially this is a reversible fluid challenge. There's some studies showing that probably about 150 mils of blood leaves the legs when they're lifted up like this, and others that show that a passive leg raise is hemodynamically equivalent to a fluid bolus of about 300 mils of fluid. So it's I guess the volume that you're giving is kind of in that range. And what you're looking for here is an increase in aortic blood flow of 10 to 12%, which predicts fluid responsiveness. To do this properly, you need real-time cardiac output measurement, which we'll talk about in a moment, to detect whether you get this increase in aortic flow or cardiac output. The advantage of this over the other mechanisms we've talked about is that passive leg raise can be used and has been a bit more validated in patients that are not that aren't intubated, so they're spontaneously breathing, and also it can be used in arrhythmias such as AF. So to do this, you want to put the patient's chest and body down flat and their legs up to 45 degrees, and then you want to wait sort of 30 to 90 seconds. The peak effect is probably at around about a minute. And as I said, you need to be continuously measuring the cardiac output. So this may be with pulse pressure measurement on the arterial line as a sort of surrogate. Other things may be using an esophageal Doppler, which we'll talk about in one of the future talks, measuring blood flow in the descending aorta. Another possibility is using pulse contour analysis derived stroke volume, which we do have available on the PICO, and we'll talk about that later as well. Or alternatively with an echo using Doppler derived velocity time integrals, or VTI, and again we'll talk about that a bit later. But essentially, ideally you've got to use one of these continuous real-time measures of changing the cardiac output as you lift the legs up to see what happens. Some of the limitations of this are to see did the passive leg raise actually increase the preload. So if the patient doesn't have a large pool of venous blood in their legs, for example, if they're wearing TEDs, if they've if they're already sort of pretty dry, they're got a contracted empty venous circulation, or alternatively if they've got high intra-abdominal pressure, which is going to sort of impair the gradient from the legs up to the chest, then doing the passive leg raise may not actually give a preload sort of bolus, and that may be the reason why you don't see any change. It may not necessarily mean that they're not fluid responsive. So we're sort of at the end, so I just wanted you to think about the hemodynamic effects of ventilation. We're all pretty familiar with the concept of lung protective ventilation, but for example, ARDS, it's not just a lung disease, but it's a disease of the pulmonary circulation. you've got pulmonary vasoconstriction, there's muscularization of the vessels, there's thrombosis of the capillaries and things. So in about 20-25% of patients with ARDS, there is acute cor pulmonale. And we need to think a bit more about the right ventricle, and we need to balance the effects of recruitment versus the effects of over-distension. So for the lungs, we often want recruitment, we want high pressures to improve the oxygenation things, but just remember that the increased pressures in the chest are making it harder for the right ventricle. So there is this emerging concept of right ventricle protective ventilation, which is slightly different from lung protective ventilation. So again, you're going to have low tidal volumes. We'll talk about the PEEP in a moment. One of the things in lung protective ventilation is that we have permissive hypercapnia, so we're not so concerned about, or we're happy to tolerate a high CO2. But just remember that a high CO2 is going to cause pulmonary vasoconstriction, and it's going to make life harder for the right ventricle. So RV protective ventilation, you might want to try and control, maybe some benefit in controlling the CO2 a bit better. In terms of the PEEP, with the lung, high PEEP is not necessarily part of lung protective ventilation, but we often use it to improve the oxygenation, but just be aware that it may be harmful. Certainly there's been a couple of studies, I think the Express trial and the LOVES trial, looking at high PEEP versus low PEEP, and although it improves the oxygenation, it hasn't really been shown to improve the outcome of the patients. And it may be because some of the respiratory benefits in terms of maintaining recruitment and improving oxygenation is offset by cardiovascular burden and maybe harms, particularly to the RV. So something to keep in mind. A final interesting point, proning, sort of topical with article recently, that proning improves right ventricular function, and it may be that some of the benefit of proning is related to reduced cor pulmonale and improved right-sided function. Okay, thanks very much.